Good evening, everyone. Welcome and thank you for joining our third discussion on COVID-19. I'm Jennifer Schaefer, the Assistant Vice President for Development for the College of Medicine and Life Sciences at the University of Toledo. For today's presentation, please submit questions in the chat box using the feature. It is down on the bottom and it's a little icon that you can click on. We will answer all questions as we go through. So Dr. Ali will give us a little insight on the neurology aspects of COVID-19, and then we will have Dr. Duggan, who will be moderating a conversation with our panelists based on questions that have been asked in the past. And we will answer live tonight questions as they come through the chat box. So feel free to use that. We are going to do our best to get through all of them. But without further ado, I would like to introduce you to Dr. Cooper. He is the Dean of the College of Medicine and Life Sciences at the University of Toledo. Dr. Cooper earned his medical degree from the University of Cincinnati, where he graduated as class valedictorian. He completed his cardiology residency and fellowship programs at the Brigham and Women's Hospital in Boston, which is associated with the Harvard Medical College. Dr. Cooper has been a part of the University of Toledo for more than 25 years. In the field of cardiology, he is known across the globe and has received more than $25 million in external funding for his research initiatives. His work has been published in numerous journals, such as the New England Journal of Medicine. I will now turn it over to you, Dr. Cooper.
Hi, good evening, everyone. So glad to have you here. And we have another exciting lineup for you about COVID-19, and we really look forward to talking with you about some of the latest information. So as Jennifer said, I'm Dr. Christopher Cooper, Dean of the College of Medicine and Life Sciences and Executive Vice President here at the University of Toledo. As a word of introduction, our College of Medicine and Life Sciences is in the business of discovery through nationally recognized research, patient care, and training of many of our region's physicians, scientists, and other health professionals. The compass that guides us through all of this is our mission to improve the health in our community and in our region. To that end, there's a great need in our community right now for reliable and accurate information about COVID-19. This afternoon, we have an exciting panel of nationally recognized leaders that include virologists that work with COVID-19 and other potentially lethal viruses, infectious disease specialists that are on the front lines of COVID care and lead many of our region's responses, and who are nationally recognized for their work. We have a pharmacist who's leading UTMC's efforts in the vaccine distribution, and we also have a special guest tonight, our chair of the Department of Neurology. Our goal through all of this is to get you solid, reliable information out to our community that you can trust. I would like to share a moment to introduce our presenters and panelists. Before that, though, I'd also like to let you know about some of the exciting things going on currently. Professors Bina Zhou and Ji Sheng, along with their graduate students, were recently notified that one of their publications was a top 5 nationally, which has already been downloaded 23,000 times on the use of artificial intelligence and machine learning to fight COVID-19. They are with us tonight. Other work at the university on the potential role for antidepressants in COVID are gaining national and international attention. We continue to support our scientists who are deep in this fight. So let me tell you about our investigators who you'll hear from tonight. Dr. Imran Ali is the Claire Marduk Endowed Chair of Neurology and Professor of Neurology and Director of Epilepsy and Neurophysiology at the Toledo Hospital. Over the past 25 years, Dr. Ali has served the university in many leadership roles. He's had numerous appointments, including the inaugural chair of the Department of Medical Education for the College of Medicine. He also serves on national committees, including the American Clinical Neurophysiology Society, the National Board of Medical Education, and the American Epilepsy Society. He has numerous publications and has received national awards and honors for his work in the field of neurology, including the American Academy of Neurology Clerkship Director Teaching Award. Dr. Joan Duggan is back with us tonight. Dr. Duggan is an infectious disease specialist and professor in the Department of Internal Medicine, as well as Senior Associate Dean for Faculty Affairs and Development and Associate Dean for Professionalism. She earned her medical degree right here from MCO and completed an infectious disease fellowship at the University of Michigan. She's received numerous awards and has received millions of dollars in research funding and has over 130 publications. Dr. Jennifer Hanrahan is an infectious disease specialist and the chief of the Division of Infectious Disease here at the University of Toledo. She earned her medical degree from the Chicago College of Osteopathic Medicine and completed her fellowship in Cleveland at university hospitals. She's written book chapters, abstracts, and peer-reviewed publications. She's passionate about education and mentoring of students, residents, and fellows, and is often invited to speak locally and nationally on COVID in the clinical setting. Dr. Jason Huntley is an associate professor in the Department of Microbiology and Immunology, and he's also director of our biocontainment facility that studies the live COVID-19 virus and other potentially lethal infectious agents. He earned his doctoral degree from Iowa State and was an NIH infectious disease fellow. Dr. Huntley has published prolifically and has given over 50 invited research presentations at national and international conferences and has been awarded more than $4.3 million in federally funded grants. In January of last year, Dr. Huntley introduced Dr. Anthony Fauci at the National Biothreats Conference in Washington, D.C. Dr. Fauci then opened the nation's eyes to a novel and deadly viral pneumonia sweeping through China, what we now know as COVID-19. We will also hear from Dr. Russell Smith, who is the Chief Pharmacy Officer, Quality and Safety Officer, and an administrator for the University of Toledo Medical Center. Dr. Smith has more than 25 years of academic pharmacy experience. He oversees all clinical pharmacy activities on the University of Toledo campuses. He earned his bachelor's degree in pharmacy right here at the University of Toledo and his doctoral degree in pharmacy from the University of Shenandoah. Russell is leading the university's COVID immunization program. I am now going to turn over the presentation to Dr. Joan Duggan, who will moderate tonight's question and answer session. But before that, let's first hear from Dr. Imran Ali.
Thank you, Dr. Cooper, for the opportunity. Can we go to the next slide, please? It's a great pleasure to talk to you today, and I'm going to try and go over some of the neurologic complications associated with COVID infection and outline some of the treatment strategies that have been identified for those patients. About 100 years ago, we had another pandemic with influenza, and not a whole lot has changed in the way we approached it at that time, except for better treatment options and obviously the advances in medicine. But I wanted to show you this slide to give you sort of a flavor of how things have changed over the last 100 years. Next slide, please. As you know, this virus is associated with very significant respiratory complications. But very early in the disease, we realized that it did have some neurologic associations as well. And those can fall into three categories, one of which is related to overproduction of inflammatory markers such as cytokines, which result in neurologic injury. It can also lead to thrombosis, which can cause stroke-like syndromes, and I'll talk a little bit about that. But more importantly, this virus has been associated with direct invasion of the brain and the nervous system, resulting in neurologic injury. When this disease first came into focus, we didn't realize that it had a lot of neurologic complications associated with it. But over the last year, we've begun to notice a number of different complications that are specific to the nervous system, either the brain or the peripheral nerves. And I'll hopefully be able to give you an overview of that in a very short period of time that I have with you. Next slide, please. If you look at the disease, it affects the nervous system in multiple ways. There is sort of widespread systemic disease affecting blood coagulation, inflammation, all of which can affect the brain, either causing stroke or encephalitis. A most important entity, which for most of the medical folks who would recognize, is the fact that it can cause a metabolic encephalopathy or an encephalopathy in which the patients appear to be confused and later on may become completely unresponsive. And we'll talk a little bit about that in a second. It can directly invade the central nervous system, causing an encephalitis, which viruses have been known to do. This is not a common complication. This is an uncommon complication, but has been identified in some patients. It can affect the peripheral nerves or the muscle and typically causes a lot of muscle ache, which is a relatively benign entity, although it's fairly painful. One of the characteristics that was identified fairly early was its involvement of the olfactory nerves. Although it's listed under the peripheral nervous system, it actually olfactory nerves, which control smell and taste, are typically an extension of the brain. And so there is evidence now, which I don't have time to show you, that it actually involves the brain in its manifestation of affecting smell and taste. Another entity which is relatively also uncommon but has been associated with infections or post-infectious inflammatory conditions, and one of them affects the brain. It's called acute disseminated encephalomyelitis, and another that affects the peripheral nervous system, which you may have heard about, is called Guillain-Barré syndrome. And we'll talk again briefly about those entities. Next slide, please. If you look at some of these are some of them are relatively minor complications, which typically don't leave any lasting neurologic injuries, and those have been highlighted in blue. The ones in red include encephalitis, post-infectious acute disseminated encephalitis, which we call ADEM for short, stroke, and Guillain-Barré syndrome, which are more severe complications. And we'll spend some time talking about this, and as well as what happens when people have neurologic disease and develop COVID infections. Next slide, please. If you look at the timeline for these infections, for these complications associated with this infection, it's fairly variable. Some of these complications occur fairly early, some of these occur late. And this, one of the things about the science of COVID-19 that we're realizing is that what we knew 6 months ago may not necessarily be the case as we get more experience with this disease. Since it's a new disease, a lot of the things that we took as gospel earlier on may not necessarily be true. So a lot of the neurologic complications which were initially seen early on can also be seen later or even before the clinical respiratory presentation. For example, some of the patients with COVID develop strokes before they develop other systemic signs. Next slide, please. Researchers from our group in our department, including a large number of residents and our stroke faculty, Dr. Jim and Zedi, early on looked at retrospectively at approximately 575 patients or 574 patients and looked at the neurologic complications. They divided those patients into those with early neurologic manifestations or those who develop neurologic manifestations in the hospital. And the take-home message from this was that about a quarter of the patients developed some neurologic complications, and those included, typically the more serious ones included encephalopathy. Some patients, a small number, developed seizures. Stroke was seen in about 1 to 2% of patients. Some of these neurologic manifestations occurred for the first time in the hospital setting. And again, seizures, stroke, as well as encephalopathy were quite common. We also reported some cases of critical illness neuropathy and myelopathy, and those have also been reported in the literature. Next slide, please. Interestingly, just as one of the things that we recognized from our work was that people with neurologic complications actually had a higher mortality rate associated with COVID infections. And so neurologic disease itself was 3 times as likely, people are 3 times as likely to die from that. The most common complication that we see is a condition called encephalopathy, which is associated with confusion initially, and then may ultimately lead to a comatose state. And this is a fairly worrying entity because we don't really understand it too well. Some of the hypotheses that have been generated for this condition include the fact that these patients may develop severe hypoxia-related injury. They may have reduced cerebral perfusion, and that may cause confusion. A large number of these patients also have renal insufficiency, may have infections, secondary infections that could cause this problem. And third, either cytokine or direct invasion of the nervous system may be seen. One of the challenges with the disease entity initially, as you may remember, was lack of PPE and our ability to evaluate these patients. So the number of patients that were originally seen with these conditions by neurologists or were tested were relatively few. Now, with better PPE, vaccinations, and our ability to go into patients' room, we're trying to get a better handle on why this complication occurs, and there'll be more information in the future. Next slide, please. One of the areas that is very close to me, as Dr. Cook pointed out, is epilepsy. And there's a paper from Spain that indicated that people with epilepsy had a higher risk of developing COVID. Additionally, as I mentioned, about 1% of patients with COVID develop seizures, and status epilepticus or recurrent back-to-back seizures have also been reported in that subgroup. In their multivariate analysis, fatality in epilepsy patients was strongly correlated with hypertension. And in another analysis, they also found that age and the diagnosis of epilepsy was associated with higher risk of death. So again, this medical condition or a neurologic condition itself puts people at risk. And that's why epilepsy is one of the early vaccination groups in our state. Next slide, please. This is a paper that compared the incidence of stroke in patients with COVID infections and looked back at flu. Can you click next again, because there's another, okay, great. And what they found was that the incidence of stroke in patients with COVID infection was about 8 times greater than those with influenza infection that has been seen recently. And these strokes included those that were cardioembolic, or they were associated with blood clots or thrombotic strokes, as we call them. And they could occur early on in the infection, as I said, or later on as well. There's more data on strokes, as I'll point out in the next slide. Next slide, please. Interestingly, a paper from France also showed that individuals who were obviously older, higher burden of comorbid conditions, and severe respiratory symptoms were associated with higher mortality associated with stroke. But what is more worrying is that there is a higher number of younger patients who develop stroke, and a significant number of them have large vessel occlusion, which is relatively uncommon compared to the incidence that was seen. So the incidence is about twice as much as would be anticipated in the general population. A significant number of these patients undergo thrombectomies and other aggressive treatment that we would do for other stroke patients. And as I said before, the incidence of ischemic stroke was about 8 times that is reported with influenza infections, signifying a much greater risk for neurologic injury in these patients. And stroke itself is considered, occurrence of stroke in COVID patients is associated with a higher mortality as well. Next slide, please. What about pre-existing neurologic conditions? And one of the good examples of that would be multiple sclerosis. It's an autoimmune condition, and it's treated with anti-inflammatory drugs, which are severely immunosuppressive and have been associated with other complications. If you look at the right-hand side slide, it actually shows that, interestingly, patients who had received anti-inflammatory medications actually had a lower risk of severe outcomes. And the disability associated with MS, which it can produce, those individuals at high risk. Other systemic risk factors were similar to the population at large: older age, other comorbidities, diabetes, obesity, etc., male sex were all associated with higher risk of severe outcomes. But it was sort of good to see that the anti-inflammatory drugs in MS patients did not increase the risk of death, because that is an important consideration. Next slide, please. I did mention to you a condition called ADEM, or a post-infectious inflammatory condition. This condition has been reported in children, especially with viral infections, but it has also been reported in association with, for example, immunizations in the old pertussis era, not the new vaccines, but in the older vaccines. But more commonly, it's associated with viral infections. It's a spectrum of disease that causes rapid loss of what's called myelin, that controls conduction of signals through the brain, and it involves both the brain and spinal cord, as it's signified in the slides on the picture on the right-hand side. These patients present with fairly acute onset of confusion. They may have seizures, unsteady gait, they have weakness, and may have other spinal cord signs and symptoms. What is what is important to remember about this condition, and it does respond well to steroids and plasma exchange. And we have seen a few cases here in Toledo as well, but it has been reported in the literature. Typically, some of these patients have responded, as I said, to steroids and immunosuppressive therapy, such as plasma exchange. Next slide, please. An entity that affects the peripheral nervous system, which is called Guillain-Barré syndrome, was reported fairly early with COVID infections. And this is an entity in which, again, associated sometimes with viral or other infections like Campylobacter, but may be associated with COVID infections, and it presents typically with progressive limb weakness as well as respiratory involvement. Neurologic signs may be seen as early as 7 days, but sometimes up to 2 to 3 weeks after onset of COVID respiratory symptoms. The treatment for this condition is IVIG or plasmapheresis, which can be performed in these patients. Next slide, please. For the scientists in the room, one of the things that has been sort of an area of interest is to look at the spinal fluid analysis in patients with COVID infection. And typically the data is fairly sparse, as you can imagine, as not many patients undergo CSF evaluation. And some of the changes are typically associated with more severe inflammatory conditions. However, this is a paper from Emory that looked at 3 patients and looked at antibody levels against the coronavirus, which is in the graph with orange lines, as well as looking at cytokine expression. And there was some evidence that in these patients, there may be antibodies to COVID-19, as well as some evidence of inflammatory cytokines when they compared it with HIV infection, a CSF analysis. And although most studies do not show evidence that the CSF PCR is a reliable marker of COVID infection in the central nervous system, and the results for that have been relatively sparse. Next slide, please. Another area for neurologic complication that is of great interest to us is what happens in children. And fortunately, children have a high rate of asymptomatic carriers and very low incidence of symptomatic neurologic complications. Although all the complications that we see in adults have been reported in children, they're relatively infrequent, and there's limited and infrequent evidence of maternal fetal transmission. Next slide. There's an entity that I mentioned, Kawasaki syndrome, which is a vasculitis that is seen in association with certain infections, but typically does not involve the nervous system, although rarely it can. Again, vertical transmission is rare, but has been reported, and I defer to my ID colleagues for more information on that. Most of the cases in neonates and younger children have been associated with horizontal transmission from other infected individuals. There's no reported transmission so far of SARS or COVID through breast milk. Next slide, please. Last slide or the last thing I want to talk about is COVID-19 vaccine and neurologic complications. Now, vaccines traditionally may rarely cause some neurologic complications, but the incidence of those complications is extremely low. And currently, there's no evidence of any neurologic complications with any of the vaccines. There were a few cases reported both with Pfizer and Moderna vaccine of facial nerve palsy. But if you really look at the number of people who received the vaccine, and the number of people who developed facial nerve palsy, that fell in the range of what would be expected in a general population. In fact, was slightly lower than the general population. So there is no clear evidence that facial nerve palsy or Bell's palsy is associated with vaccine. And as I stated, there's no evidence of any other neurologic disorders so far associated with it. In fact, a number of neurologic organizations have strongly come out in favor of utilizing vaccine in neurologic patients. And clearly there is evidence that patients with neurologic disease are at a greater risk of morbidity and mortality associated with this infection. Next slide. The summary slide here, just to recap, COVID-19 is associated with neurologic disorders. Delirium or encephalopathy or confusion is the most common one, although stroke and seizures can also occur. Typically, the cognitive and the neuropsychiatric manifestations are relatively poorly defined at this time. We don't really have enough data on that. Next slide, please. And I would like to end this with a final slide, and thanks to all the infectious disease and other healthcare providers, especially nurses, who have done a phenomenal job, and to our patients who unfortunately have had to suffer through a fairly severe illness, and we are all there for them. So thank you very much, and I'll end at this point and pass it on to Dr. Huntley.
Okay, thank you, Dr. Ali. So hello again, everyone. I'm Jason Huntley. Next slide, please. So tonight I'd like to talk briefly again about the currently approved vaccines, some of the vaccines you may have heard of that may be approved perhaps by March, questions you have about getting one dose versus 2 doses, efficacy and safety. So again, just to remind everyone, there's 2 vaccines that have emergency use authorization by the FDA. Those are both mRNA vaccines. These are the intermediate between DNA, which is the blueprint, and how you make proteins. So these encode the spike protein. Both require 2 doses. The Pfizer vaccine is given 21 days apart. Moderna is given 28 days apart. If you focus on the right side of the graph, again, the overall efficacy for both of these approved vaccines is about 95%. So we've had questions about, I've heard about the side effects during the second dose. Can I just get 1 dose? So let's look in the middle of this slide. The efficacy after 1 dose is only about 50% for both vaccines. And in the case of Moderna, it takes about 14 days after that first dose before you get that. So again, if you only get 1 dose, you're decreasing from 95% down to 50%. This is not a good idea. Even after the second dose, and again, the data is still coming, but in the case of Pfizer, you're only about 91% protected within the first 7 days. After 7 to 14 days, that's when you get the full 94, 95% protection. So the simple answer is both of these vaccines do offer great protection, 95%, but you need to get doses. And while you're in the middle of your vaccine regimen, you still need to wear a mask. You still need to socially distance. You're not suddenly Superman and immune. And again, if you focus on the middle where I have efficacy after the first dose, it's only about 50%. And you need that booster, that second dose, to really educate all of your immune cells to produce neutralizing antibody to completely kill the virus. Next slide, please. So again, there's been a lot of media reports about new vaccines. I'd like to focus on 2 that are probably the most likely to be put forward to the FDA, again, either later this month or possibly in March. So again, just so we're comparing apples and apples, you can see Johnson & Johnson here, or J&J. As opposed to the mRNA vaccines that are currently approved, the Johnson & Johnson vaccine is a modified adenovirus. This is a chimpanzee adenovirus, so you won't get any cross-reactivity with the human adenoviruses. People are excited about this vaccine because, number 1, it can be stored in refrigerator temperatures, and number 2, it can be given just as 1 dose, and the protection is about 72%. Yes, that's less than the 95% with the currently approved vaccines, but we always worry about what we call compliance, or patients returning for the second dose. So for the US population, the Johnson & Johnson vaccine may be really good. Again, 72% protection, only about 28 days after, and you only need 1 dose. The second vaccine that may be coming is a recombinant protein-based vaccine. This is from Novavax. Again, this is the spike protein, but as opposed to either using a modified virus or mRNA, they're actually making a recombinant protein, or the spike protein, in insect cells. This vaccine requires 2 doses. It's given 21 days apart, and the data so far indicates that it's about 90% protective, and that protection is about 7 days after the second dose. So again, we have 2 currently approved vaccines. They're very safe, very effective, about 95%. Johnson & Johnson is exciting because you only need 1 dose. Novavax, you need 2, but they're about 90% protective. So next slide. We've had a lot of questions about these SARS-CoV-2, that's the virus, or COVID-19 variants. So again, comparing apples to apples, if you look in the middle of this table, you'll see the overall US efficacy. That's the protection or efficacy of these vaccines in the US population. Now, you've also heard about the UK variant. Pfizer and Moderna have both reported that in people that have been vaccinated here in the US, the antibodies that are generated by those vaccines still neutralize or can kill the UK variant. So there's no concern there. Now, you've also heard about this South African variant. Pfizer is still analyzing how their antibody protects against that, but Moderna has reported that their vaccine stimulates really high levels of antibody, actually much more than what they think you actually need. And despite a 6-fold reduction in virus neutralization, their vaccine still works extremely well. Again, it's going to take some time before we actually know efficacy against infection, but in the lab, there's pretty good indications that both Pfizer and Moderna stimulate antibodies that can neutralize the UK variant, and although it may be decreased 10, 15%, also the South African variant. Now, again, this is supported by, and again, we don't have authorization. They haven't submitted their materials to the FDA, but Johnson & Johnson and Novavax, both vaccines are also showing protection against both the UK variant and the South African variant. You can see here Johnson & Johnson, their protection against the South African variant dropped about 15%. Novavax, although it provided about 90% protection against the UK and the US strains, it dropped about 30% to the South African variant. But these are still really high levels of protection. Of course, viruses continue to mutate, and as we have really high infection levels throughout the US, the more people that are infected, the more chance for the virus to mutate. In terms of how quick it mutates about 2 times slower than the flu virus and about 4 times slower than HIV. So yes, it is mutating, but not as fast as some other viruses that we know. Next slide, please. So is it safe? Or people are asking, is it safe for me? I mean, let's put things in perspective again. We have at least 27 or 26 million, this changes, documented cases or people who've shown up positive for coronavirus in the US. And to date, as of yesterday, we've immunized or vaccinated 34 million Americans. So again, if you put this in perspective, is it safe? In addition to the clinical trials where both Pfizer and Moderna immunized about 40,000 people, we now have about 34 million Americans that have been immunized. And even if there was a 1 in a million chance that there's some kind of adverse reaction happened, you would hear about it. And we don't hear about it. Again, we have questions about who can you trust on data. Go to the CDC COVID data tracker, which is shown here. You can see how many people have been vaccinated. You can see the adverse events. This vaccine is safe and it is effective. Next slide, please. And is it safe for me? Again, you can go to the CDC and see how many, you can look in the brackets here. You can see the percentage of men and women, of different age groups, young and old, of whites, Hispanics, blacks, Asians, different races. This vaccine, both the Moderna and the Pfizer, has been given to millions and millions of people from different age groups, different ethnicities, racial backgrounds. It is very safe and it is very effective. And you need to get both doses of the current vaccine to get 95% protection. Okay, so now I'll turn it over to Joan and we can try to answer more questions.
Okay, so for the next 15 minutes, I'm going to try to cover most of the 50 plus questions that we did not get to from the last session that have come in. And I'm going to start with a question for everybody to tee off from Dr. Huntley. And this question really gets to the heart of a lot of what our patients are saying. I don't even get the flu shot. I'm uneasy about how fast they created this vaccine. How can I be sure that down the road there will not be some long-lasting side effect? And what can you say to me that will talk me into getting the vaccine? So let me open that up. Let me start with Dr. Hanrahan on that and then pass that on to Drs. Huntley, Ali, and then Russ Smith, our head of pharmacy. So Dr. Hanrahan, what would you say to a patient that asked that question to you in clinic?
Yeah, so what I would say is that most importantly, we know what COVID does. COVID kills a lot of people. We have a huge number of deaths in the United States at this point in time. We also know that the vaccine, which, Dr. Huntley just presented all this great data, we know that millions of people have had the vaccine and not having any problems. the only way that we're going to be able to put a stop to the current pandemic is for people to get vaccinated. So people either have to all get infected or they all have to be vaccinated. And one of the important things is that the more virus is reproducing in the community, the more opportunity there is for variants to arise, the more mutations there's going to be. So the longer this drags on, the worse it's going to get. So really the only way to control it is for people to get vaccinated. And there's tons of safety data now. And, that's what I would say, that it's safe.
Yeah, and if I could just follow up, Dr. Hanrahan's exactly right. And in terms of, all the let me just point out that the FDA reviews it both internally by career scientists, but they have an external advisory panel that has over 20 academic members, as well as people from different pharmaceutical companies, clinicians, et cetera. So this is reviewed by people like us who have no vested interest in it. And again, they look at all the data from different age groups, different demographics. And again, if there were any concerns, this would have been voiced, or people, there'd be contraindications, people who were suggested not to get it. And at this point, there's no data that anyone cannot get it.
Well, then let me tag on to that from one of the questions that came up about side effects. So is it safe for everybody? Have they looked at it specifically in the elderly? So one of the questions that came in was that one of a patient who says self-identifies as elderly says they have they're a cardiac patient, elderly. They're concerned about the side effects they read about, like rapid heart rate. Has this gone through all the necessary safety testing, the Pfizer and the Moderna vaccines?
So,
yes, or Dr. Hanrahan.
I was just going to say that, so, the clinical trials included people in a lot of different age groups, but a lot of the questions that we're getting are, is it safe for someone who's getting chemotherapy, or is it safe for someone who's getting this specific therapy? And the answer to that is that no, those specific subgroups were not necessarily included in a way that we have large enough numbers that we're able to give those specific recommendations. But what we do know is that people who are older actually tend to have less side effects than people who are younger. And so this vaccine has now been given to a lot of people who are in nursing homes, the most vulnerable population, and actually they're doing quite well with it, having less side effects than younger people, healthcare workers who are getting these vaccines. So what I would say is that while we may not have all of the data yet, that data will be forthcoming. And if you are someone who has a heart problem, then you are at increased risk for getting severe disease with COVID, and the vaccine is recommended.
So this is then the other side of the coin for vaccine, people who are reluctant, that's one side. And then the other side are people who really want to get it. And so we have a couple of questions I'd like to target towards Russ Smith, our head of pharmacy. Patients are asking if we're pretty sure that the supply line and supply chain is going to be good for vaccines. Are we going to run out of Moderna? Are we going to run out of Pfizer vaccines? And when are we going to start moving this out to other people in other groups, people age 35, school teachers? What is the rollout plan, and what will our role be in this? Big chunk there to you, Russ.
So, absolutely. Thank you, Dr. Duggan. So our vaccine rollout, we are currently in phase 1B. Here in Lucas County next week, we're going to be vaccinating the teachers as well as individuals 65 and above. I really encourage everybody on the call to go pre-register at the Lucas County Health Department. So when you go to their website, make sure you're using Chrome. Don't try to use Internet Explorer. It won't work at their website. So go there, use Chrome and pre-register. So that way, when you are eligible, no matter what population you are in, you will receive the email from them that there is appointments available and you can go and make them. So that should be first step for everyone. So with the vaccine supply, when we receive an allocation each week, and so the Ohio Department of Health determines how much each hospital, health department, or pharmacy is receiving, and we then subsequently make appointments available for the public based on that allocation. So when you look at the health department and you don't see appointments out in the future, That's because we don't know what our vaccine's going to be beyond next week. Next week, we knew we were getting 300 doses to vaccinate. So I let the health department know, post these 300 appointments, and they do that on Thursdays. So on Thursdays, they post those appointments, and when they're gone, they're gone. It'll look like there's no appointments available, and there most likely won't be until the next week. So make the health department website a favorite of yours and continue to watch for that site. Look under the pharmacies, look under the different hospitals. So there's lots of different options there. As far as security of having the vaccine and having enough doses. So every time we give a first dose, we are guaranteed that second dose. So to date, we have had 0 issues. The second dose of everybody's vaccine arrives a week or more ahead of time, so that there's been 0 issues with people being able to get their second dose after receiving their first dose. So that shouldn't be anything that that you all in the public should be concerned about, that the second doses are secure. Today, the governor did talk about escalating the rolling out of the vaccine, and that the allocations are going to be going up and more vaccine is going to be going out to the communities. So we've not seen the details of those shipments yet, and whether there's going to be more providers available. And we have not seen what phase 1C is going to look like yet. So we have not seen the details of who is going to be the next population that is going to be vaccinated. So for now, I know there's a lot of 80-year-olds and 75-year-olds out there who are still looking to get the vaccine. Continue to monitor the Lucas County website and take that first appointment that is available, whether it's Moderna or Pfizer. Out there, just like Dr. Huntley said, both vaccines 94, 95% effective. We're looking forward to that Johnson & Johnson vaccine, hopefully later this month, early next month, getting out there so that there is additional vaccine in the supply chain for everyone. So I think I checked off your answers there, Dr. Duggan.
So you did, but I'm going to circle back to one thing. Let's go back to, again, talking about vaccinating the teachers and getting the schools back in session. So can you go over once again what information you have regarding the governor's plans to reopen schools, if that's been released, and get teachers vaccinated? So what's the plan?
So the governor's goal was to get the teachers vaccinated by March 1st. There is a large number of educators here in Ohio. Ohio, or just the public schools in Lucas County, the teachers wanted more than 10,000 doses of vaccine. And when you spread that across the state, that they had to spread the teachers out because Ohio's allocation was not enough to vaccinate all of the schools, all the counties at the same time. So they were spread out over 4 weeks. This is the second week of vaccinating teachers, and Lucas County was in the second group of counties. This will continue on for 2 additional weeks after Lucas County to reach out to the teachers. And the goal is to reopen the schools so that we can reopen the economy, so the single parents can get back to work, so the workforce can isn't homeschooling anymore. And that is a top priority of the governor, so that students can receive the high quality education that they receive and have that interaction with their peers and their teachers, and that's really a top priority of the governor, so that the schools can be back in session.
Perfect. So in my last 6 minutes, I'm going to swing over to Dr. Ali in a minute, then a couple of infection control questions to Dr. Hanrahan, one more to Jason Huntley, and then an open question for everybody in the panel. So Dr. Ali, in your slide sets at the very end, you had a poem that came up, and it mentioned the words brain fog in it, written by, I think it said, a 36-year-old teacher from Georgia. We're getting a lot of questions about some of the cognitive sequelae that people get, some of the long-term neurologic symptoms that people have when they've had COVID. And so for people who are long haulers, people who are experiencing significant cognitive sequelae, if you look into your crystal ball, what do you think they should be doing to try to help their symptoms? I realize there's not a lot of data on this. And what do you think will really be the best thing to try to avoid those kind of complications?
So it's a very good question and a complicated one. So I think, as you said, that there's not a whole lot of data on cognitive impairment in COVID patients, although there's a paper that was early in the summer that looked at some cognitive testing, but it was fairly basic cognitive testing, and they did show that there was some impairment in patients. The assumption would be that there potentially could be some cognitive issues that patients may face, as especially the ones with more severe disease as they recover from it. The approach that I would take at this point is that for them to have a full neurologic evaluation, including neuropsychometric testing, which is essentially detailed testing for memory and other functions, to actually do two things. One is for us to better understand if there is objective evidence of cognitive impairment, and two, to develop strategies to treat that. So there are potential medications that can be given to people with different types of cognitive impairment, but we would have to select those based on what we find on our evaluations. So I would say the approach would be, if somebody has those symptoms, to seek help with a neurologist and then move forward with potentially working out strategies to help them. But I would anticipate that some patients may have what are called the long haulers, may have some issues. Potentially, most of them should get better with time.
Perfect. So, Dr. Hanrahan, I'd like to talk a little bit about some infection control questions. And the two I want you to tackle are this. The first one is, somebody noticed that there's not a lot of influenza around this year, and how does that relate to COVID? And the second one is, when can the masks come off?
Yeah, so the first question is actually really interesting. We assume that because people are wearing masks, that has decreased the spread of influenza. There may also be something about not being able to have multiple epidemics at the same time, but Dr. Huntley may be able to answer that better than I can. But I would just say that I think the masks actually have made a difference. People are paying more attention. With regard to the question of when the masks can come off, that's actually much more complicated, and it's going to have a lot to do with when we reach a critical number of people who have immunity, either by natural infection or by vaccination. It's going to be some time to come, because people are going to continue to be at risk until we have substantial immunity in the community. So I think we're going to have to wait. I'm hopeful that it's going to be by June, but other people think it may be longer. So I wouldn't be in a rush for that yet.
Perfect. So question to Dr. Huntley, and then there'll be one final question for everybody on the panel. So Dr. Huntley, we've gotten a whole bunch of questions about the situation in the United Kingdom, including their variants and some of their strategies that they've announced to try to, such as delaying the second dose for the AstraZeneca. Any information that you have on whether or not these UK variants are affecting, especially with the AstraZeneca vaccine in the UK, are they affecting the COVID situation over there, or are they still able to get protection, achieve herd immunity, et cetera, including with the strategy of stretching out the AstraZeneca, the Oxford vaccine? Any information on that?
Yeah, so we know that the British government is actually trying right now the ability of AstraZeneca and the Pfizer vaccine as just one dose. They're also trying to mix and match vaccines. I think we need to, really take a U.S. focused approach, which is, again, the FDA approved either Moderna or Pfizer as their own vaccines given in 2 doses, and Pfizer, Moderna. Now is not the time to start mixing and matching, or again, people being worried about the potential sore arm after the second dose and skipping it. So we need to follow the current regimens. Again, if the British government or I know it's being pursued by some of the pharmaceutical companies, if new data comes out that we can alter or perhaps extend, and even the new CDC director noted that in extreme circumstances, if there were extreme shortages in vaccines, we could potentially stretch that booster up to 2 weeks. And again, she said to be very careful, but only if there's no other alternative. We could possibly stretch it. So even the CDC director has noted that we could. Back to your other question about the variants, again, with the infection rates being so high, both in the UK and here in the US, and as we've heard today, with that then driving viral mutations, again, we still need to wear masks, social distance, while we're also getting the vaccine in as many people's arms as we possibly can. We need both of these strategies. And, you know, it's important with Super Bowl weekend coming up. I know people probably want to have parties and get together. Now's not the time to let down our guard. You've heard this number, right? If we get 70 or 80% of the population immune, we may be able to talk about getting rid of masks. But with these variants coming, the UK variant's already here. You know, the South African variant is probably going to pop up. Either it's going to come from South Africa or it's already here. We just don't know it, right? It independently will arise, or new variants may come up. So again, then we have questions about, does the vaccine protect against these new variants? We don't know, but only if we continue with the current mask wearing, social distancing, and vaccination will we get to the point where we can start to ask questions about, can we take masks off?
So I'm going to finish up with one brief question and then turn it back over to Dr. Cooper. And I'm going to start with you, Dr. Huntley, and then have you pass it off. This is a real key question. You touched on it a little bit before, but people want to know, and I know you're not going to say the British National Health Service, where do you turn for trusted information on COVID?
Yeah, the CDC is absolutely the best place to go. If you really want to dig into data about the vaccines and who it was given to and how safe, you can go to the FDA website and literally pour through hundreds of pages of clinical trial data. But if you just want simple information that's reliable, the CDC website is absolutely the best.
Perfect. Dr. Ali, where do you go? Anything different, CDC?
No, CDC. And you know, there's a paper coming out every half an hour or so, and there's more literature coming out every minute. So we're trying to keep up with that, but absolutely agree that the CDC is the best place to go.
Okay. Dr. Hanrahan, where do you go for information?
So the Centers for Disease Control is excellent. And one of the things I really like about it, it has information for both lay people and for healthcare providers. So actually, they also have some information in other languages. But I would also say if people are interested in learning about some of the long COVID symptoms, the British Medical Journal website, bmj.com, actually has some really nice information for patients that's very helpful. So I would also encourage people to look at that.
Yeah, and I know Dr. Hanrahan has served as an advisor to the CDC throughout the pandemic, has been on a number of websites or WebExes and things with them. And Russ, where do you go for information? Where's your trusted source?
So like everyone else said, definitely the CDC. But when it comes down to vaccine distribution and the most recent information in Ohio, I can go to the Ohio Department of Health website. They have a lot of information there. And they put up the governor's slides from what his distribution plan is. So that's a great website and great resource for residents of Ohio.
Perfect. So I'm going to turn this over in a minute now to Dr. Cooper to handle any of the questions that came up during this session. And we're going to try to get some of those websites posted for you, the information for the links to them, so you can check those yourself and get additional information. It's a very fluid situation, and there's always information coming out. So Dr. Cooper, over to you.
Dr. Duggan, thank you so much. To all of our panelists, thank you so much. I do appreciate tonight's speakers who are doing a lot of work to help our communities and nation with this COVID crisis. We are all very appreciative. You know, it's interesting, this is the third of our town halls, and what I find is each time we think, oh, what's next? And within the month, there are new information which are evolving about the COVID pandemic, and there's certainly plenty to talk about. And I'm sure by next month, we'll have even more updates for you. To keep you informed, we will be having another COVID town hall. We don't have a date set yet, but we will get that out to all of you soon. As we come off of this event, I'd like to ask you to respond in the chat box. We do follow your questions. We'll collate them and do our level best to make sure we get those into the next town hall. There also should be a short survey to let us know what you need. And again, if you can fill that out, we will try to be responsive to you. We continue to be in a critical state in dealing with the COVID virus. One of the interesting things I learned from our speakers tonight is that as more people get vaccinated, we lower the risk of variant or mutant viruses from developing. So think about that. We all have a responsibility in our community to advise our friends, our neighbors, our family, our loved ones to get the vaccine when it becomes available to them, because it not only protects them, but it also protects all of us from the development of variant or mutant strains. In brief, the less virus is out there, the less virus that's out there to mutate. I'd also like to thank our speakers and the region's healthcare providers, all of our healthcare providers across the region, who've been on the front lines of battling this virus for nearly a year now. Tonight, to all of our attendees, I'd ask that you follow the guidelines, sign up to get your vaccine, and keep you and your loved ones safe. Thank you so much, and have a good night.